Okay, thank you. I hope I can finish in 10 minutes. But so our case is a 57-year-old man who has multiple comorbidities: hypertension, chronic kidney disease, non-ischemic cardiomyopathy, low AF, TIA, stroke, COVID pneumonia, drug abuse. He had a CRTD for optimization. The guy kept coming to ER with heart failure symptoms, and then we had his echo that showed it looks like a functional MR, a tethered valve with a severe mitral regurgitation. So the patient was brought to the discussion at the heart team platform, and because of the comorbidities, the case deemed to be a mitral valve clip candidate. So the patient taken to the clip. Clip was done. Excellent outcome. Call it a good day. Patient was discharged home. However, after like 3 months from the procedure, the patient came back to ER with worsening symptoms. And at this time, we had a TE that showed that the leaflet, the posterior leaflet, totally detached from the clip, and the patient had, again, severe mitral regurgitation. So as you can see here, that in the 3D, that the posterior leaflet is totally detached. So the patient was discussed again in the heart structure meeting, and we again said we're going to go for a second trial of clip. So the patient taken back, the other clip was done, and this time was not in the middle, was more toward commissure, and finished deployment. We call it mild, moderate MR post clip, and we call it a day. Patient was discharged home with a follow-up. He was fine with the class 2, but after a year, he presented back again with the same symptoms: shortness of breath, BND, orthopnea. And again, investigation showed that he had now detached 2 clips with a recurrent severe mitral regurgitation. So, as you can see here, both clips were attached, and the MR is significant. And this was also confirmed with the 3D. So my question to the panel, or look to the audience, what would you have done now? Would you do medical therapy? Would you subject him for another tear? Would you send him for conventional surgery, or you consider transcatheter? So let's go with the first option. Who will do medical therapy only? Nobody. Nobody? Okay. Who will go for another tear? 1, 2, 3. Who will send them for conventional operation? Okay, we have 6, 7. And who will go for transcatheter mitral replacement? Oh, majority. Okay.
Mohammed, if you allow me.
Okay.
Yeah, I like the surgeon. They say single leaflet detachment, and intervention it say single leaflet attachment. So it depends. Yeah, SLDA is attachment, but the surgeon look at detachment, which is fair. I think in this case, it's not a technical issue. It's the functional MR with remodeling of the LV. So the LV for every year, almost few months later, he remodeled and pulls everything and detached. So I think part of the treatment is to initiate medical therapy. And the medical therapy is just to make sure that you work on the remodeling. That's just the moment.
So we will go look to this. If you look at the evolution of the mitral clip went through multiple evolutions with either with like mitral clip from Abbott or even from Pascal. And we're able to achieve a very good outcome. And if you look at this graph, that the technical evolution grows up, and with the volume, the residual MR become low, complication become low, and single leaflet detachment become also low. And if you look at, whenever you do more cases, your time in the cath lab goes down, your complication goes down. And even a clip showed a very good outcome in terms of reduced revascular hospitalization for heart failure and even for recurrence of MR. But you have to keep in mind, if you have a patient with residual MR, their mortality is increased. And even this goes with either primary MR or secondary MR. And if you look at the multiple trials, 2/3 of the cases, they are straightforward cases, it's okay. But 1/3 of the cases, they are a complex anatomy. And those group of patients that they might have a suboptimal outcome or failed clip. But and this is demonstrated clearly, if you do a complex anatomy, compared with non-complex anatomy, you still have some group of patients that end up with higher secondary MR, or +2 MR. And if you look at different techniques, sometimes you use different kind of clip, you'll be able to achieve a better outcome. And this was shown before, but I think when you reach up to this level, like when you have a grasping stone with calcium, or you have a big gap, or very tethered posterior leaflet, you really should think about alternative approach. So tear is good approach, and low risk and low morbidity, but still not everybody can fit to the tear. Especially if you have anatomy that's difficult, you have to keep in mind sometimes when you do tear, you will prevent patient from going back for further transcatheter therapy, and it's very important learning curve. When you have more cases, you will have excellent outcome. So here is what we suggest, that if you have this kind of anatomy, the patient should really go for alternative approach. And one of this is the big, like big flail leaflet, cleft. Patient have calcification at the tips and rheumatic disease. And also, again, this is what we, like a theme of suggestion, that keep in mind when you do clip that this might not be a good factor for the patient to go for a repair. Going back to our case, just to remind you, so what we did decide, we will decide for transcatheter mitral therapy, we'll do Tendyne. So we send the patient, what's Tendyne? Tendyne, it's the transcatheter therapy. It has the valve here, tether and apical cap. It is very user-friendly. It is full operated, repositioning, and you can fully retrievable if you have a suboptimal outcome. And we have two types of valve. We have the standard profile, we have the low profile. All concerns come because if this valve can cause LVOT obstruction. If you use low profile, you might prevent this. So we did the coronary angiogram for our case. As you know, there's non-ischemic cardiomyopathy, so his coronaries were actually normal. And you can see here the 3 lead of the CRTD. So this case was sent to measurement. So we do echo and CT assessment. So I'm not going to spend too much time here, but this is, I show you how we screen the patient. So the TE images will send to the company, so it can look into the end systole, end diastole, and they look into the posterior and anterior leaflet like height. Then we do a lot of details in the CT scan. We look into the size of the annulus. We look into annular segmentation in systole and diastole, looking into the trigone to trigone and to posterior diameter and peridiameter as well. We do that in systole and the diastole. We look into MAC, because initially when this trial started, MAC was contraindication to go for Tendyne, but now actually MAC is one of the indications to do Tendyne because you prevent doing a catastrophic post-op complication. And we also look into if do we need to do a balloon valvoplasty before or not, because sometimes this patient, they have a very calcified like subvalvular apparatus or fibrotic. Sometimes you'll not be able to expand the valve, so this is another thing to look at. We also look at the sizing. How should we size the valve? So we fit the parameters we get from CT and echo, and we practically, you should have this patient fit into the 33 large standard profile when we have AP oversizing 4%, intracommissural oversizing 28%, and perimeter area oversizing 20%, and this is the perfect for this patient. Then we look into the LVOT, because the most important complication is LVOT obstruction. We look into neo-LVOT in systole and diastole, and practically you need an area more than 250 millimeters square, and the distance between the valve and the septum should be more than 10 millimeters. And after that, we fit this valve into a 3D model for the CT scan, so to see how this valve will interact with the septum and with the aortic valve. So this procedure started by getting a regular access, femoral and arterial, just in case the patient need to be in ECMO. But when center become more experienced, these steps might be avoided. Then we do, we put a pigtail. This pigtail will go through the aortic valve, because you want to get the LVEDB in the beginning of the case, and also you want to check the LVOT gradient after the case. Here we're getting the measurement. So this case starts with doing a mini thoracotomy into the, I will not call it fifth intercostal space, but because we get a service echo and we decide really where is the apex, and this also get by the aid of the company. They give you exactly where is the apex. After we do the cut down on the thorax, we access the pericardium, and we control the apex just to have a very good control After that, after we assess, we make sure that the area of the puncture is the same area that's been decided. Oh, sorry.
Can we have the slides again for 2
Give
minutes?
me 2 minutes, I will finish. Okay, well, for the sake of time, I will skip this. Then we'll pass the system. System will go through the mitral valve, as you can see here. We put the system echo-guided and also angio-guided. After that, we'll deflate the balloon and remove the wire and the balloon from the system. This also confirmed by echo. After that, we start deploying the valve from outside. We have cardiac surgeon, second operator, and third operator. We start deployment here, as you can see here. We also confirm with 3D for the positioning. We confirm also with angiogram. This is how we align the valve. And after that, we confirm again with angiogram. And this is when we remove the delivery system. As you can see here, from the first deployment, we have a mild paravalvular leak anteriorly because there was anterior clip there. After that, we reposition the valve, and we have 0 paravalvular leak, and we finish the procedure. So the patient had an eventful post-op course. He had some issues with his respiratory status because of his smoking, but the patient discharged home day 6. And this is his post-op echo, showed very good gradient with 0 MR. So outcome of Tendyne, we don't have time, but it's very safe. It is a successful implantation, 97%, 0 conversion, 0 mortality. 1 year outcome mortality is 26%. 2 year out mortality is 40%, but keep in mind, this is a very sick group of patients. No residual MR, their quality of life is better, and their 2 year outcome showed decreased hospitalization. So this is what we suggest if you want to go for a TMVR. If the patient is not considered good candidate for repair, then you do the TMVR the TMVR workup. If the patient have no LNU LVT obstruction, he goes for TMVR. If he has a high risk of LNU LVT obstruction, he will go for either conventional surgery, conservative therapy, or sometimes you push the limit by doing septal alcohol ablation, repeat CT scan, and then maybe consider him again for the procedure. Thank you so much.